aim to showcase applied health research across the interdisciplinary fields of implementation and improvement science. So to learn more about upcoming training or seminar event, do give us a follow at the Twitter account of NIHR ARC in South London. So joining us today is Anthony Gilbert and John Bateson. Anthony is a research physiotherapist in the Royal National Orthopaedic Hospital NHS Trust. He's currently in the final year of his PhD, funded by an NIHR fellowship for clinical doctoral research, investigating implementation of virtual clinics and patient preference. John is Deputy Director of Strategy and Improvement in the Royal National Orthopaedic Hospital. He's also the QI lead for quality improvement and clinical audit network of the National Orthopaedic Alliance. So Anthony, John, welcome. We look forward to learning about your experience in the rapid implementation of virtual clinic during the pandemic. I'll now hand over to you.
Excellent, thank you. I'm just going to share my screen. Can you see that okay? Has that come up yet?
Not yet.
I've got that little circle thing that's going around, so it's trying to do it. Sorry, hopefully it won't take too long.
Should be okay now. There you go.
Yeah. Super. Put my slideshow up. Always takes longer than you want, doesn't it? Okay, so hopefully you can see that. Can you see that all right?
Yeah, it looks good.
Excellent, thank you. Right, so thanks very much for the introduction. I'm Anthony Gilbert, as has already been said. So I'm a clinical research physio at RNOH, and I'm really grateful for the opportunity to be able to talk to you today with John about our experience of implementing virtual clinics because of COVID. What I'm going to talk to you about now is our experience at RNOH about implementing virtual consults. And what I'm covering was published last year in a paper in BMJ Open Quality. So I'm going to share the bottom line results with you and some of our take-home messages. And I'm going to add some of my personal reflections on improvement and implementation, and in part because of my PhD as well. And then once I've done that, we'll go straight over to John, who will offer his reflections on the work from more of a strategic and improvement perspective. So I just want to acknowledge Health Education England and the NIHR, who funded my clinical doctoral research fellowship, and also the University of Southampton, where I'm just in the final stages of my write-up for my PhD, and I'm investigating patient preferences for virtual consultations. So I do apologise, I'm going to be bringing some of that in as well. I do keep talking about preferences, so I will be dropping some of that too. So if I just cover what actually happened last year, we were one of the first trusts at the Royal National Orthopaedic Hospital to be granted an Attend Anywhere licence. And Attend Anywhere's use is widespread across the NHS in England now. I think 170 trusts used Attend Anywhere for their video consultations because of COVID. Just a bit of background on the hospital. So the RNOH is an elective hospital. So we have no accident and emergency. The majority of our care is planned. And essentially we've always strived to be a COVID clean hospital. We've got a number of protected emergency pathways. And back in March last year, there was a very clear goal set and established and communicated across the trust to reduce face-to-face care. So I remember it so well, the email coming through. It was on the 5th of March, and I was recruiting patients for one of my studies in outpatients. And on a personal level, it still gives me nightmares when I think about how my PhD changed from a lovely planned research investigation into a hypothetical mode of practice, suddenly into this accelerated real-world implementation because of a global pandemic. So for me, it required quite a rapid epistemological shift in my data collection, And the following week, I was invited to join what we called the non-face-to-face action group. And this, I'm going to lay this point a little bit. It was a core group of people from across the trust. So it was multidisciplinary. Everyone brought different skills to the table. We had operational managers, myself as a clinician and researcher. We had a project manager, we had quality improvement staff, and we had volunteer staff. So we had a range of skills and expertise that really did spread across the organisation, which was really helpful. So one of the first things we did back last year, once this goal had been set, we needed to contact our patients to let them know what was happening. So we didn't have access to a texting service that was routinely operational at this time, and it had to be done manually with phone calls. So our admin team were absolutely fantastic. The majority of our booking service were retasked to contact all patients for the first Monday. So the start of this was Monday, the 16th of March. You can see it's burned in my brain. But once that Monday was completed, they then did Tuesday and so on and so on. So we had to get through all of these patients. All staff were asked immediately to triage their patients to either essential face-to-face, as in they need to come in, or virtually it would be clinically acceptable. And patients were then, if they were triaged to virtual, they were given the choice between a video call using Attend Anywhere or a telephone call. And across the trust, a whole load of work was going on to enhance the hardware and the software. We had to set up user accounts for Attend Anywhere, things like that. And very quickly, the core team that I mentioned before and pictured on your screen, we had to become familiar with the technology as we were the support for the clinicians on the ground. We collated all the issues that we encountered and found, and we discussed them at our daily meetings, which again was really important. Our quality improvement team were excellent, and they guided our methods using the Institute for Healthcare Improvement approach, and they guided us through PDSA cycles as we worked through this improvement in real time. So it was a big team effort. So at the Royal National Orthopaedic Hospital, and this slide is the results taken from the paper that we published last year. We previously did some phone clinics. So our pre-target to implement virtual consultation, so prior to that, was typical at around about 93% face-to-face. So we didn't do any video calls before, and it was all phone calls. But within 2 weeks after that target was set, we achieved our goal of having less than 20% in-person consultations, and this was maintained thereafter. And I would say it was a massive team effort across the organisation to do this. But what was quite interesting when given the choice for those who were triaged to virtual, the majority of patients opted for a phone consultation, and perhaps in the discussions afterwards we could talk through why we think this might be, but I think that's a really important implementation consideration. People chose a phone rather than the video call if given the choice. So something that was important to note as well, which in hindsight would have been worth formally capturing, was the fact that many of our clinicians would triage people to virtual but book them in for a phone clinic. And some of our clinicians didn't really entertain video calls early on in the pandemic. So patient preferences and what a patient would prefer to have, which is the subject of my PhD, they're clearly mediated by clinician preferences and what a clinician wants. And this is something that empirically stood out a lot in my data collection during the later stages of my PhD. So we collected some outcomes. We provided an end of consultation questionnaire that patients and clinicians were sent directly after their consultation. So it didn't Attend Anywhere. As soon as the consultation finished, there was a web browser would pop up onto the screen, and it didn't take very long to complete, but it just gave people the opportunity to give their feedback, and that was really helpful to collect data on satisfaction. So satisfaction was high for virtual consultations, but interestingly, 94% of patients would opt for a phone call again, whereas less than half of patients would go for a video call again. And again, quite interestingly, about half of the staff would go for a video call again, but whereas they could go for a phone call. And I think there's a key role for thinking about preferences and implementation processes. If we think about what a preference is, it's a total subjective comparative evaluation, and an individual will prefer the option that brings them the most utility or benefit. And if we're going to be doing an improvement project around virtual consultations or around anything, any sort of change project, and people prefer to stick with the status quo because they feel it's more beneficial for them, there's some work that will need to be done around that. And I believe changes will less likely be sustained if people prefer the old way or the status quo. So that's something that I think is quite important for us to think about when we talk about improvement and implementation. So I'm going to share some of the key take-home messages that we felt were important. When we look at the challenges of conducting a massive quality improvement project during the pandemic, I mean, it was such a huge, very fast-paced piece of work. I think the urgency of sharing our take-home messages are possibly a little less important now. But one of the key reasons we wrote the paper was we wanted to get our learning down. We wanted to share it, and this was actually published in, I think, the end of May last year. So it was accepted and published fairly quickly, and it's had a huge amount of interest. And I've been told personally, and my colleagues have been told, that it was really helpful to help others work through bringing in virtual consultations. But I still think the take-home messages are relevant now to this project and then also to other projects too. So the use of quality improvement methodology kept us focused and on task. Personally, it's not something that I'd ever used before, and I found it really helpful. I'm someone who's working with normalization process theory for my PhD, and there are obviously other frameworks, which I'm sure many of you will be aware of. And although we didn't formally use MPT when we sat down and planned this project, there were lots of elements that came up and sort of came to the forefront of my mind during this program. So we did a lot of work around sense making. We shared lots of information with staff about the aims and the objectives and the reasons why we need to have virtual consultations. The goal was clear and explicit. The expectations of what was required of clinicians were set out. There was very little work, I don't think, needed to be done around getting commitment for virtual consultation use during the pandemic, particularly after the lockdown came in. I suppose I'm thinking here about the cognitive participation element of MPT. As you'll all no doubt remember, the news was full of, quite frankly, horrific reports about COVID. We had the scenes from Italy, we had the Nightingales being pulled together, we had reports from other hospitals across the NHS about being overrun with critically unwell patients. Our Prime Minister was admitted to ITU. It didn't take much in general to get patients to engage with the concept of social distancing. And actually many of our patients were thrilled that they had the opportunity to continue to access their care, albeit virtually. Lots of investment went into the operational work, which is the collective action element of MPT. Huge amounts went into skill set workability of clinicians, and much of the support for patients to engage with virtual consults was delegated to clinicians. But interestingly, some of our clinicians weren't so good at using the technology, and patients were able to help them out. So this really sort of shaped the way that patients and clinicians interacted with each other, and you could argue that's the normative and relational restructuring of MPT. And that was completely acceptable during the pandemic. We invested lots of effort appraising virtual consults. We set up a questionnaire, like I said, for patients and clinicians to complete after each consult, which is reflexive monitoring. And this shaped many of our PDSA cycles. As things were identified, we would then work through these and look to make changes in order to improve them. So whilst this isn't necessarily supposed to be an empirical example of MPT or implementation science in action, it was more of an improvement project. This is something I've personally reflected on and something that I'm currently writing about in my thesis. So the amount of resources and staffing that were required were monumental. And I don't think we could have achieved this project and the outcomes from this project without the resources we had to hand. We had investment and support from our senior leadership, and John's going to talk a little bit more about this. Communication was so important across the team. So we had about 10 of us working on a day-to-day basis on this. We were constantly WhatsApping each other. We were running from office to clinic to IT department, carrying multiple boxes of headsets and webcams whilst on the phone. We had to be in touch all the time, and we were constantly talking to each other, and that was really important. So as I mentioned earlier, I'm interested in patient preferences, and we found that the forced use of virtual consultations due to COVID has had positive and negative consequences. And some of my PhD has captured the experience of patients, clinicians, and managers. And we've developed a model that orientates patient preference in the context of organisational and clinician preferences. And I'm going to labour the point, because if a clinician or if an organisation doesn't want to use a virtual consultation for any reason, it's unlikely it's going to get used in practice. And I think this is likely to be the same for, all of the implementation activities that we do, whether it's virtual consults or any sort of change program. And there are obviously lots of things to think about. As I mentioned earlier, bringing pragmatic improvement methods close with implementation theory, I believe, has a potential to be an effective way to bring about change. COVID-19 was just the perfect catalyst for a whole load of change across the health service. But as this wanes, it calls for more than ever for effective implementation methods. And I think bringing these two sort of like paradigms together would be of real benefit for NHS change. So we had lots of people involved, and John's going to talk a little bit about sort of the culture of the organisation. But I want to emphasise that although John and I are talking today, there are a huge number of people who've been involved in these endeavours. Our admin staff, our clinical staff, our improvement team, our research team, our clinicians, our patients. This is a collective cross-organisational effort that's resulted in some important and key research and improvement outputs. There are many people from within the RNOH who will be able to comment on many of these aspects of how we delivered these projects. So I think the paper on the top left of your screen is the one that's captured the most attention, which I've essentially summarised here. John's going to talk about some of our research, some of our leadership reflections of this implementation sort of project. The paper in the middle, the Rapid Design and Implementation of Virtual Pain Management Programme, was a fantastic piece of work led by my colleague Debbie Williams and the rest of our pain and shoulder team, where we converted our face-to-face pain management programme into a virtual one. And what was great about this, there was a bit more time, so this was later on last year. It was underpinned by the literature, and you can see the picture below. We did a systematic review to look at the content of other virtual pain management programmes, and we developed the programme in partnership with our patients, and we engaged with them. It was underpinned by engagement and patient evaluation as we iteratively designed the programme. What I found very interesting is the paper on the top right. So our implementation and improvement work was hailed as a success. But what we captured over time through our data collection and our observations were a number of issues, which we explored nationally in a survey. And if we define successful implementation as ongoing, sustained use, we could argue normalisation, we need to understand the issues that the stakeholders who will be using it face. You can't fit a square peg in a round hole, and without COVID, without the emphasis for social distancing, our work might have been trickier. And then finally, one of my recent PhD papers, we investigated the impact of COVID-19 on preference. We sampled patients from our previous discrete choice experiment, and even the ones who were strongly in favour of face-to-face before the pandemic, they still preferred a virtual during the heights of lockdown. And again, COVID provided a useful catalyst to get virtual consults rapidly implemented. And without this emergency situation, I wonder if it would have been as successful as we necessarily observed. And you could argue that it's not been sustained sort of after lockdown, and John's going to talk a little bit more about that. So some of the take-home messages on what we did and what we found, or just to summarise. So rapid implementation of virtual consults was complex, took up a huge amount of resources that were all needed. Satisfaction was high, but patients and clinicians don't necessarily prefer video calls. We've seen the natural rate of face-to-face has increased, and John's going to talk about that. This research informed the later stages of my PhD. There are a number of factors that influence preference, which in turn influences its use. And COVID-19 has certainly influenced that. We're not seeing the high rate of virtual consults we saw during lockdown, and we need to see whether or not video call is acceptable in the long term beyond COVID. I think there's a lot of research required on this around the efficacy of remote consultations, and that seems to be something that holds the clinical teams back from using it. They don't believe it's as effective or as safe. They're less likely to want to engage. And I found from my research that clinician preference, and I've spoken about it in this talk, clinician preference definitely will influence what patients think. And if we consider this from a longer term implementation perspective, I think there's still some more work that we need to think about the role of preferences. There's been so much energy for change during the pandemic. I can't help feeling that this sort of thing wouldn't happen as successfully in your typical non-pandemic setting, in a typical job where you're working within your normal working hours. Everyone in this mobilised together to make it happen. And it was a really inspiring activity to be part of. But what is important now is to think about how we harness that to mobilise change in the future. So that's me come to the end of my bit. So what I'm going to do now is I'll stop sharing and I'll pass over to John, who's going to offer his reflections from a more strategic perspective. I'll stop sharing.
Oh, sorry, Anthony, can you carry on sharing? You can just share mine if you're okay with that.
Yeah, that's...
Sorry, it's probably going to be easier.
Okay.
Thanks. Thank you, Anthony. You've hit all of the questions that we all want to know about how special it was during COVID, I think. I enjoy Anthony's reflections on that moment when his PhD plans were torn up and thrown in a wastebasket and had to start again, because he's so sanguine about it. And the flexibility that Anthony shows is a very extreme version of a flexibility that everybody showed, I think, around that time. So that team that Anthony described was drawn from all sorts of different grades across the organisation. And they all showed that kind of flexibility. There was a moment, wasn't there? And I vacillate between being, feeling sort of glowing and warm about this and feeling a little bit depressed thinking back on it. There was that moment when everybody was in this together. And, in the good moments, I think we've maintained quite a lot of that in our organisation, even if not in the country. But it was definitely something going on at that time where people like Anthony were able to sort of move things around and come and join teams that were nothing to do with what they'd been doing before. And I speak often to the people who are in the team, and I hope, certainly tell me, they would, wouldn't they? But I hope they mainly found it a really, really refreshing and exciting addition to their work. And many people have taken away the things that they did and that we did in that setting and taken them back to their day job. I don't be too rose-tinted spectacle-ish about this. I mean, clearly we are facing all manner of challenges and people are doing their best in difficult circumstances now, but I do like to think we've changed the way we work a little bit. Anyway, I'm getting ahead of myself because I want to talk a little bit about that at the end, and I think everybody on the call will have their own strong views about where we're at. As Anthony said, I mean, it's vital to remember this was in a unique context, but I would balance that a little bit by saying it was also a hugely ambitious thing we tried to do. So just to give a context about the virtual clinics as the example we're looking at, our trust had been talking about moving towards more virtual clinics. We'd reached 7% after about a year and a half of saying our target was 20%. So our stretch target at that point was 20%. And for all sorts of reasons that you can probably guess, to do with people not being keen, to do with them very complicated, to do with actually all the work that needed that Anthony described that we did in the end in 2 weeks. Running around doing technical stuff, installing things, and ordering and delivering headsets, all that kind of stuff. So instead of a stretch target of 20%, we went for a 2-week target of 90%, 80% what we went for. We arrived at 90%. So certainly things were, there was something about the stars aligning in order to be able to do this that we can't ignore. But it was also quite an impressive turnaround. I mean, everybody, I think, pretty much across the NHS and in lots of other settings moved to doing virtual work, but we did it very quickly and I think pretty effectively, I think it's fair to say. So it's a fair question to start with. Under COVID, there was a definite wide agreement that this was both urgent and had to be done at speed. Not many people disagreed with that across our organisation, and as Anthony pointed out, including patients. When we spoke to them, and I'll come back to that as well in a moment. We had, by this point, established a certain amount of distributed leadership. It was already very apparent at the beginning that this couldn't all be command and control type work, but we also had this sort of goal command structure in place. So we had some distributed leadership and some decision-making capability, and we were sort of feeling our way through it. But those things actually worked to our advantage here, because basically once we'd set a task in train, it was delivered locally, and that was sort of accepted. And everybody talks quite often about the suspension of bureaucracy and how many people found that very liberating in terms of implementing change. And certainly in this particular context, we did. And I'll talk about why I think we were able to do that, actually, because I don't think it's a given by any means, even though COVID was a state of emergency, is arguably a state of emergency. To take us back a little bit before that, the trust had begun and was on an improvement journey. We were late to this. Lots of trusts have done a much longer and better and more impressive, what I'm calling here an improvement journey beforehand. I joined the trust about 2.5 years ago, so I'd been there for a little while before COVID began, but not that long. And actually, we'd committed to the idea of quality improvement, QI. We'd committed to the idea of using the IHI approach pretty much. But all we'd actually really done is train the executive. So they did we got UCLH, another one of the academic health science networks, to deliver some training in-house, but it really only reached the executive, plus or minus a few other people who were brought in. And it wasn't really having impact because they weren't leading projects. And we'd managed to put together a small team, and we'd begun to put ourselves about and get well known and so on. So when I say small, I have 2 people in my team and an admin person. It's still the same size actually. But you know, we are out and about all the time, and that's not subject to this, but it's really important, as everybody probably knows, to be seen and to be visible and to be engaging with people. And to talk to Anthony's flexibility, we had this great multidisciplinary team who were sort of incredibly eager to engage. Everybody wanted to do something, but then when we got together, there was a new level of respect. Everybody was listening to one another. Nobody felt like an expert in the room, frankly. I mean, it was something to do with that. It was new to everybody. And so whether you were a band 3 or a band, 9, everybody was listening to one another in a way that I've not really seen in our organisation. I'd not really seen in our organisation before that. I think we've kept some of that, to be honest, but maybe not all of it. And people were eager to take on responsibility. They were eager to act. So there were a number of things that were unique to this whole situation, I think. Anthony, can you move me on a slide? Sorry, I probably should have done it myself. And I'll go quickly through this. We did good quality. I mean, I'm calling it good. I'm not saying excellent or outstanding. This is standard practice, but we did it quite well, I would argue. The clear shared aim, by which I mean we had a smart aim that everybody understood and nobody really thought was a terrible idea. Most people thought it was a really good idea. So in terms of aim, great. In terms of engagement, it helps that you have a clear message, obviously. But actually, as Anthony pointed out, we had a bunch of people. So we were able to not just do some trust level comms, which we did, of course, but we're also able to be out and about and talk to people. And if you were able to choose, you would always engage through talking with people on a one-to-one or a small number basis. It certainly works. We very rarely get the opportunity, but we did good engagement, I think it's fair to say. And it was more than just sort of telling people what was happening. The good engagement, as I'll come on to mention, was about the methodology of listening to people, and they begin to see everybody who's not directly involved in the project begins to see something they've raised is changed, and it makes a huge difference. So that's the engagement, it's the full engagement cycle, not the just telling clearly. And definitely these few bullet points are drawn with a slight change in emphasis because I'm an improvement person, but they're drawn from the reflections of our senior leadership team, which is the second of the 2 papers that John helped put up earlier. And everybody acknowledged that the resource is something that we tend not to do as well as we would like, and I assume that's the same in every certainly is in every NHS organisation I've worked for. We would always like more resource, and we think we would do better with it. And for once, possibly the first and only time in my life, we actually had the resource we needed, I think. And we also set up very well, considering it was quick, good data capture analysis and shared that quite often. So we had all sorts of things going on during the pandemic. Our medical director did a lovely sort of open reflective letter on a regular basis. It feels like it was every day. I might be slightly wrong about that. And we were able to reflect occasionally in that, the work you're doing is making a difference. Look what's happening. And that was really helpful. And finally, I think the idea of having this simple, clear, common methodology really helps. Although we hadn't reached very far into the organisation with basically just using the IHI method, plus or minus a bit of large-scale change. So we talk a lot about PDSAs, very common. Anybody who's come from any other organisation kind of recognises it, but not everybody who'd been in our organisation for a long time did. But this simple, clear methodology really, really helped. And in particular, it helped us give reassurance to the executive team. So I mentioned the gold command. They were happy to let us get on with it because they all of the executive team were involved in that, understood that we were using the methodology, so risk was mitigated, and learning was being captured. And as we look forward, that reassurance that having a clear common methodology gave the senior leadership team has continued and is something we want to build on. I mean, it's one of the most powerful things about using a method like that, which is a very simplistic method, but actually doing small cycle changes and gathering data on it really does help reassure senior leadership that they don't need to micromanage, and that was very powerful for everybody. And I think is not about the alignment of the stars, but it's actually a sort of something that we are taking forward. Can you go to the next slide, please, Anthony? So, you know, it wasn't all perfect. We did 2 weeks with another few weeks afterwards, obviously. And I'm just sort of reflecting on some of the things that we're not sure we did quite as well as we would do in different circumstances. Anthony's touched already on the patient engagement work. We were really lucky to have Anthony come and join us because although many of us have worked in patient engagement, nobody had done specific patient engagement around this. We may well have insisted on everybody using video conferences. We might not have video calls. We might not have kind of acknowledged quite so clearly that many people just prefer phone calls. Anthony already had insight into that kind of work. And that really helped. And we did, of course, try to gather some feedback from patients, and we got good patient engagement stuff, but we didn't do the pre-work with patient engagement that we might have wanted to do. Therefore, you know, I suppose my reflection on that is that we needed to do and have more ready to go kind of patient engagement in our organisation. And we've since then begun work on a patient charter. We're using the IWE statements, some of you will know from National Voices. So it's led to a whole bunch of other work, but it wasn't perfect. The second point is something that I think is common to most organisations that have adopted virtual clinic technology. Because the choice of platform was free, everybody used it. But not everybody was happy with it. So there's been quite a lot of meetings, some of which I've been involved with and some of which I've thankfully not been involved with, about what the right choice of platform for this is. And everybody has their say. So we went with one, but you know, people are not necessarily happy with it. And it's partly because I guess the engagement around what platform to go with and what we wanted from this. You know, for example, do we want a platform that allows easy use for MDT settings or for engaging a third-party clinician, something like that? None of those things are available on Attend Anywhere, and many of our clinical colleagues would have liked that. And we definitely, in thinking of the diffusion of innovation curves, insofar as it's useful, I'm not sure how far over the hump we got. We certainly didn't reach the very unwilling, and you know, that's fine actually. And we do know there are some of our colleagues who will never use a video call. They don't really use the telephone, it can help it. But maybe we didn't go quite as far as we should have done with some of the people who were persuadable, and I'm not sure about that. It's hard for me to judge it, but I think maybe that speed did probably, you know, push people along quicker than they wanted to, and they kind of maybe resent it. Next slide, Anthony, maybe. Just use what we actually did, the practical thing of it, and the reason I want to put this in is because we used, some of you will recognise this as the Leadership for Large Scale Change repurposed into a rapid learning coordinator framework. Basically, what we're trying to describe here is that we just kept coming back with data each day and making decisions in the daily action group meetings, which meant, of course, you have a pair of hands who go out and pick up information and do work. And it was really striking, more so than any project I've worked in, how quickly things were changing in this project. This model, this rapid learning coordinator, which is not as formal as it is in some places, some people have actually appointed roles. I would quite like to do that. I'm still trying to explore how I might fund it. We've taken this model and we've used it in a number of settings. So since we've gone through some virtual clinic stuff, we've used it on our wards. We've managed to make a real impact on some wards about our length of stay, which has always been quite an outlier, I think it's fair to say. So arguably some of the things we've done on our wards to reduce length of stay have been low-hanging fruit, but nonetheless, we have to do them. We've used that on the wards of rapid learning coordinator framework, and it works really, really well. We've used it. We've had a lot of struggles around outpatient flow for all sorts of reasons. We've remained a largely COVID-free hospital, which obviously means we've been very limited on how we manage our outpatients, and of late having all sorts of trouble with people trying to get in without wearing masks and other things that we don't allow. So we've done a lot of this. We use the rapid learning coordinator framework for our outpatient flows all over the place. And we plan to use it in other bits and pieces. We're going to be rolling out an electronic pharmacy management tool, which will probably surprise people that we don't have one already, but we don't. And the implementation of that will be using the same framework. So this is, I suppose, this is my takeaway from, once you take away the unique situation of COVID and all those kind of things, what is it that's left that allows us to continue hoping we will be able to implement change in a reasonably rapid process and make it stick? And this is one of the things I think we're finding. So next slide, Andy. What actually happened? Has it been sustainable? Well, this is where we're at. This was the year afterwards. It's roughly the same now. It's just this happens to be the most recent one we took to the board. As you can see, it's no longer at 90%, but it shouldn't be at 90%. We don't know. I mean, Anthony may have some, informed guesses about this. We don't really know what the right number should be, but we've stuck at quite a high number here. So 20% was our stretch goal a long time ago. It feels like now, wasn't that long ago. And in fact, we're around about 40% at the moment. And that's partly because we still have quite a lot of IPC restrictions in place, but it's been, and there's been very little hands-on work to keep this going. This is basically, it's been left to its own devices within reason and back over as business as usual. And this is roughly where it's come around. So I would say it's certainly had, there is, whether this is the right number and whether it's going to go a bit down or go a bit up. And clearly you can see the video numbers haven't risen massively at all. And I feel, my personal view, and I think Anthony's, is that we need to do more work around this, because there is a lot of capacity and potential there, particularly for our patients who travel long distance, because we're a tertiary centre, and potentially have more follow-ups that are just checking in. So there's probably a lot more to be done there. But there's no doubt that this is now a modality that's part of the way we work. It's one of the tools that our clinical teams use on a regular basis. So I would argue that this has shown sustainability over this period. I mean, the acid test, of course, is once we abandon all IPC restrictions and all those other things, will it still maintain? So we will see. But the sense I get from the clinicians who are on board with this is a new modality they're going to use more and more, especially when the technology is a bit more reliable, which is, you only get one chance to show it's reliable, and then people leave it alone for a very long time. I think that's my last slide, isn't it, Anthony? Oh no, look at that. This is a rehash of what I said before, really. This is where we're using the rapid learning coordinator model, so you can see for yourself the kinds of things we're doing and how we're trying to use the learning we've taken from COVID to make sure we're able to rapidly implement work elsewhere. And that was my last slide. Thank you very much.
John, you're on mute.
Sorry. Thank you, John and Anthony. So I think we have one question in the chat box. Kelly from NHS Confederation. Her question is, she would be interested to know whether you have or are looking to work with local system partners on virtual wards.
It's a very good question, to which I don't know the answer.